Oh, didn't see you there. So you want to learn about endotracheal intubations. But let me show you how to do it. That's a great question, Sport. The indications for endotracheal intubation are the inability to maintain airway patency, the inability to protect the airway against aspiration, the failure to ventilate, the failure to oxygenate, or anticipation of a deteriorating course that will eventually lead to respiratory failure. Contraindications for endotracheal intubations include severe airway trauma or an obstruction that does not permit safe passage of an endotracheal tube, a Mallampati score of 3 or 4, or other determination of potential difficult airway. Special consideration is given when a cervical spine injury is present and the need for complete immobilization of the C-spine makes endotracheal intubation difficult. Consider an emergency cricothyrotomy in such cases. You want to ensure that all your equipment is in good working condition and then select the appropriate size blade for the patient. Assemble all your material you could need close at hand. Here are the different blade types and sizes. Macs are curved and Millers are straight. Assembly is pretty straightforward. You just hook the blade onto the laryngoscope handle, and there you go. Select the appropriate size ET tube, and as you can see, these can be wobbly. To ease the process of ET tube insertion, use a stylet to help guide the tube. Much better. Once a patient is in proper position, head tilt chin lift or sniffing position, it's time to hyperoxygenate the patient with 100% oxygen for approximately 2 minutes. This kind of buys you time when you decide to intubate and that the patient won't become deoxygenated. Once again, we just want to make sure that all our equipment's working before we're going to use it. My ET tube inflated, which is good. Placing the stylet into the tube to help with guidance. Still attached to the syringe filled with air. Attaching my laryngoscope here. This all would have been done prior to as well. So, you're going to insert the blade between the teeth into the hypopharynx. Be careful not to pull back. You could break some teeth and that's bad. Instead, you want to go in and use leverage and lift the laryngoscope upwards and forwards without changing the angle of the blade to expose the vocal cords. Once the vocal cords have been visualized, you can pass the ET tube through the cords. Once you've seen the tube go through the cords, you can go ahead and secure your tube with your 10 milliliter syringe full of air to inflate the cuff, and then remove your stylet. Next, what you're going to want to do is confirm placement by attaching an in-tidal CO2 monitor, as shown, and then your BVM, and begin to ventilate. Other signs of confirmed placement would be visualizing chest rise and fall. And lastly, you want to auscultate, listening to both the right and the left lung.